is today. We are extremely excited today to have Dr. Bhat from University of Delaware to discuss motor challenges in children with autism spectrum disorder. But before I introduce our speaker, let me go over some housekeeping issues. As you know, we continue extending CMA credits for our Tech Talks and our ID series presentations. We will distribute the information via email to those that registered for today's event. If you did not register prior to today's talk, you can still obtain CME code information from Deborah Rees, and she will post her address in the chat box today. We are taking a break for the summer and we'll resume our ID series in the fall with two great seminars. The first one will be by Jennifer Sims Murtada, who is a researcher at the Cancer Center here at Krishna Care, and I think she will present her really extraordinary research on breast cancer. And the following one will be with Luke Rasmussen and his team from Northwestern University, who will talk about reproducibility in research. So these are really two seminars in the fall that you do not want to miss. So again, I'm very excited to have Dr. Bhat here presenting her research. Dr. Bhat is currently full professor with tenure in the Department of Physical Therapy at University of Delaware, with a joint appointment in behavioral neurosciences in the Department of Psychological and Brain Sciences. She was also recently appointed director of the Developmental Research Pilot Project Program, known as DRPP, for INBRE, our great INBRE program in the state of Delaware. She obtained a PhD in biomechanics and movement science at University of Delaware and completed a postdoctoral fellowship in autism at the Center for Autism-Related Disorders at Johns Hopkins School of Medicine. She's currently the PI of a very large R01 and also of several foundations-funded grants, and has been extensively funded by the NIH, either the National Institute of Mental Health or the National Institutes of Child Health and Human Development over the years. She's a teacher, has mentored numerous students, postdoctoral fellows, and faculty. She has also received many awards, and the last one in 2022 when she received the University of Delaware Mid-Career Excellence in Scholarship Award. Dr. Bhat is also a prolific writer with multiple peer-reviewed publications, very impressive publications, numerous commentaries in physical therapy journals, as well as book chapters and blogs. She's also been invited to talk all over the US and the world, from Australia to Germany, and was recently a keynote speaker at the North American Society for Psychology of Sport and Physical Activity, which was in Toronto in Canada just in June. So thank you so much, Dr. Bhat, and we are really honored to have you giving us some information about your research, presenting your research to us.
Thank you so much. Claudine, can you hear me and can you see my screen?
Yes, we can hear you and see your screen.
Okay, awesome. Thank you for inviting me to the Innovative Discovery series. I am excited to share some of the research I have done in the last many years. I will start off here. I want to say that I've worked with children on the autism spectrum for the last since 2009, since 2005 actually. So for many years now, and this is a population that is very near and dear to my heart. You know, the students who work with me are extremely committed to working with children. So the first half of this talk is actually looking at large data collected in families affected by autism throughout the US. And the second half of the talk is really about what my students do in my lab in terms of developing interventions, providing interventions to children with this diagnosis. I want to thank the students involved, my collaborators, Specifically, the first half of my talk, as I said, is about the SPARK study, which is a national study, and the SPARK study team at the Simons Foundation have generously shared their data with me and also my funding sources, and of course, our children and families who participate in our studies and help us do this research. So I will break my talk into somewhat four parts. The first one will focus on early detection and how movement and motor issues in autism can support early detection of autism. The second part will be really talking about the Cinderella status of motor problems in the field of or in this diagnosis of autism. When you look at the definition of autism, a lot of difficulties are captured. The primary ones are the social communication and repetitive behaviors. There are general delays in cognition and language. Even sensory issues are now captured since 2018, but motor issues are still absent from the ASD definition, which is very common across different fields. So, in the fields of developmental psychology or motor development, in as such, is always on the side, is not recognized enough. So that's not surprising. But I will talk a little bit about why that is important, because that access to motor services then become a problem. And that is the third part of this talk, talking about access to motor services, physical activity programs for this population. And then lastly, I'll go into work done in my lab, where we've looked at the effects of various types of movement interventions and how they benefit children with this diagnosis. So what should we be expecting when we are talking about motor difficulties in autism spectrum disorder? What do we see in children? So motor difficulties are one of the earliest signs in children who go on to develop ASD. And so these are young infants at that time. And what we know is they can have delayed motor milestones. They can have postural delays, sitting, crawling, walking delays. They might have reaching, grasping delays, but typically those are not going to be severe enough for people to pay attention to it. And so that's where I think we are missing the boat. That is, if you look at the screeners for autism, none of those recognize any aspect of movement. They typically focus on the definition of ASD and what is associated with that definition, which is social communication skills, repetitive behaviors. Motor delays are sort of taken out of the picture when screening is happening. But what we know from studies that have been done is that the motor, even though these children will walk, right? They will sit, they will walk, they will achieve their motor milestones with some delay. The gap between children with autism and their peers tends to increase in terms of motor performance as they get older. So much that by school age, they are functioning at a level of a child maybe half their age. So, as a 6-year old, maybe their motor skill performance is at the level of a 3-year old. And if you look at the types of skills that are affected or difficult for a child with autism, they are not on the along the lines of basic skills like reaching or walking. Their challenges are more along the lines of complex motor skills. So anything that requires multi-step action, that is hard. Planning of those multi-step actions is hard. Visual motor coordination, multi-limb coordination, coordinating both sides of the body, that type of movement is challenging for them. And also within the US is known as dyspraxia or developmental dyspraxia. So that is clearly should be a focus of what you're, when you're looking for movement challenges in autism, that is one thing you want to be aware of and recognize and try to assist through therapy or through accommodation. The other perspective, this is having challenges with multi-system skills. So from a neurological standpoint, autism is a neurological disorder, and in terms of connections in the brain, what is more affected are these long range connections between one hemisphere and the other, or between cortical structures and subcortical structures. And so what requires integration across brain regions, those types of skills are hard. And the skills that I just described, multi-limb coordination, visual motor coordination, bilateral coordination, motor planning, all of those require that long range functional connectivity and structural connectivity. And that makes it hard to do these types of skills. So socially embedded skills, doing skills where you're aware of what's happening in your surrounding and matching to the movements of others, cooperating with others, doing things that where you can anticipate somebody's action and act appropriately, that is hard because they're not always tuned to what's happening around them. And then learning through imitation or planning of different movements, in general, as I said before, in fact, overlap with cognitively challenging skills, right? Motor planning is not just motor, but it is, in a way, a cognitive challenge. And so often I'm asked, okay, why is all this important? And so the reason why we think this is important is because if you don't address it early on in preschool age or infancy, that will expand and continue to be a problem in school age and later in life. So these problems, as I'll show you in the data, will persist later in life. And parents, are making up for those difficulties, right? So they sort of help the child in functioning, but truly the child takes a longer time to become functionally independent. And that eventually will lead to them not being engaged in terms of movement play. They don't want to go out and play, they don't want to engage in physical activity for different reasons, and therefore that can impact their physical and mental well-being because they are sort of not part of the group. They've missed those opportunities of social interactions and play with others. So let's start with the first part of this talk, which is motor delays. And how do motor delays contribute to the diagnosis of autism? And so this here, I'm going to talk about data collected by the Simons Foundation. Again, this is a national study where there are different sites. The data is collected by the Spark study team and then shared with researchers who are interested in analyzing the data. And so these are data from 18,000 children with ASD, but there were also, so these are only tracking the development of children that are from families impacted by ASD. So the control group here is, in fact, unaffected siblings. They have never developed ASD, never had an ASD diagnosis. So that's the comparison group here. And these were children between 2 to 15 years. The limitation of these data is that they were asking the parent to recall the delays that their child had in infancy and the second year and third year based on any memorabilia that they have, any pictures, videos, baby books that they have. Based on that, these data are being collected. So they were asked to comment on when their child sat without support, when their child crawled, walked, and the only fine motor skill I have is feeding self with spoon, so we'll go with that. And then we have skills that were first words used, or when the words were first combined, and then when the child started speaking in sentences. And based on two measures, the Alberta Infant Motor Scale, which provides normative data, skill milestone by milestone, as well as the MacArthur Communication Development Inventory, which also provides skill-specific normative data. I have made judgments about whether the parents are saying their child has no delay, mild delay, moderate delay, or severe delay. Okay, and these are all ages in months. The other part of the data set is you have data from standardized measures. So a measure called the Social Communication Questionnaire, which helps you understand the child's social communication delay. The RBSR, or Repetitive Behavior Scale, helps you understand the severity of the repetitive behaviors they have. DCDQ is a measure of motor difficulties or motor impairment. And then lastly, parents were asked to give parent reported outcomes. So how affected is your child's cognition, language, as well as function, whether they have no delay compared to their peers, some delay, they're slightly below their peers, or they're significantly below their peers in terms of their development in language, cognition, and function. So initially in the first half, we won't get to these measures, but I just want you to remember that I will get to them in the second half of my talk. Right now, we'll only focus on the early milestones and what are parents saying about their child's early milestones. So this is a graphic of each skill, and I have tried to break down whether there are delays and what the extent of delay is. So blue is none, orange is mild, gray is moderate, and yellow is severe. So on the right here are all unaffected siblings. These are the different skills that we are looking at: motor and communication delays in autism. And right off the bat, you can see that the ASD group, the group that developed ASD later, has more of these other colors, not blue, but other colors compared to the unaffected group that never developed autism. And that's consistent across all of these skills. What is interesting is that there is a lot of blue, right? So in sitting, crawling, there is a lot of blue. There is less of these other colors. And so what you see is in the ASD bar, the amount of other colors, orange, gray, and yellow, will slowly increase in magnitude. These are all our motor skills, and then these are our communication skills. So the point I'm trying to make is that the disorder itself evolves with time. You're not going to be able to diagnose the disorder easily within the first year. Everybody is kind of unsure if something is autism or not. So it's hard to diagnose this problem early in life. And in general, there is not a lot of yellow, which is severe delay, in sitting, crawling, walking. There is some, but not a lot. And so the point I'm trying, but still there is delay, right? It's not all blue here. And so the point I'm trying to make is that these delays tend to be mild to moderate. They are usually not severe. And so you shouldn't be going in looking for that as a clinician who's trying to diagnose autism. If you're looking for severe delays and saying, oh, they're not there, oh, there's no problem, let's move on, then you're not recognizing the fact that there are mild to moderate delays, and that can help you add to your diagnosis because it's giving you cumulative information beyond the other symptoms that you might see. And I'll get into the other symptoms in a little bit, because at least 56% of these children who eventually developed autism had walking delays, 74% had feeding delays. And so there is a subgroup of children that have significant motor problems, which could be used as markers, but currently our screening tools don't. Okay, so the next point I'm trying to make is, can I actually predict autism based on these motor and communication skill data? So what I have done here is use raw curve analyses, and I'm reporting the sensitivity of predicting autism, because we have two groups, right? We have the ASD group and the non-ASD group. So we can look at when they accomplish these milestones, we can take their ages, and we can look at whether the milestone ages help predict autism. First, just look at motor, then look at motor added on with other skills. So truly, just using motor won't be very helpful, right? Because that is around 73 or 74%. If you look at just first words, that is also around 73%. But if you combine motor and first year communication milestones, which is using first words, then that improves the prediction from 73 to 78. So adding motor to communication delays and making a prediction is a better way to do this. The same thing for combined words, which is a skill in the it is around 80%, and adding motor makes it go up to 83. Now, in the second year, it's probably easier to recognize autism than the first year. So I would say, in both cases, there is an appreciable jump from 0.73 to 0.78 or 8 to 83, where you could consider using motor milestones along with communication milestones to make predictions about whether somebody will have autism. Gross motor milestone delays tend to be mild to moderate. We shouldn't be expecting severe delays. If it's a severe delay, it's probably not autism, it's something else like cerebral palsy or something more significant. In the first 2 years, adding motor might enhance sensitivity of predicting ASD. So look for those mild to moderate delays. That is also a marker. In fact, there are other things that go with that, and specifically hypotonia is something that is often reported throughout the childhood, not only in infancy, but infancy, preschool, and school, and all the way into adulthood, where that should also be considered a marker. And I'll get to some others in a future slide. So overall, use cumulative sensitivity to predict autism and consider motor as a intervention domain for this population. If you look at early interventions of autism, everything is at a desk. It's all about talking to the child. There's no movement involved, and there is not always a referral for physical therapy or any kind of recreational therapy. And so that also needs to be added within their plan of care, specifically not just communication or fine motor skills through OT and such. Okay, so that is the first message. The second part of this talk is about more Spark data, and that's in school age children. And this is work I have done with Dr. Tulsky and Dr. Bolton. Um, and that, again, is getting at the same issue but at a different age. So typically we think autism as traditionally as a social communication disorder. But in the more recent years, as people have understood the neurology of autism, they have recognized it as a multi-system disorder, and gradually the definition has evolved. So if you look at the DSM-5, around 2013, the modification was made where sensory issues were now recognized as part of the. So there are two categories, the two diagnostic categories of autism: social communication and restricted and repetitive behaviors. And sensory issues were recognized under restricted and repetitive behaviors. If there are also certain general delays associated with autism that are expected, and so those are captured under specifiers, and those are cognitive and language delays. But if you look at the criteria or the specifiers, motor is not mentioned anywhere. And so right now it has this Cinderella status where, people are saying, hey, it's important to consider, it needs to be recognized. And that's what I'm going to show you now. That is, why does it need to be recognized? Okay, so if you remember the measures that were discussed quickly early on, there is a measure called the Developmental Coordination Disorder Questionnaire. It's a 15-item questionnaire. It can be administered in school-age children. It's been validated for children 5 to 15 years, but you could go slightly above maybe, and it would still work the same way. And in this measure, what they find is, so these are data collected from the Spark families who have a child with autism in that age range. Parents have completed the questionnaire. And you see, and I was surprised to see this because what I thought was, children get better over time in terms of their motor issues. And so this may not be so substantial, but 87% of this population, parents were reporting risk for DCD, so a motor delay. And if you look at whether there is a dual diagnosis of DCD, only 15% of these children were actually having a diagnosis of DCD, which is a provision in the DSM. So in the DSM, if you have motor problems, it's not going to be recognized under autism because it doesn't exist there. You're supposed to give a dual diagnosis of DCD, but clinicians don't seem to be doing that. Even though parents recognize motor issues in their child, clinicians are not recognizing it by giving a co-diagnosis of DCD. And so that is where I'm saying that these are pervasive problems, but still under recognized for this population. Okay, so as I said, this should change over time. I was surprised to see this graph, which is basically the red portion of the pie, which is children with DCD risk don't change a whole lot with time. Early on, parents are unsure. So this is cross-sectional data from the DCDQ measure, 5, 6, 7, all the way to 15 years. And what you're seeing is early on, maybe 80%, around 80%, 77 to 82% families are concerned about their child's motor skills because they're giving time, right? Perhaps this is something that comes later in life. I'm not concerned about it. But by 8 years, the pattern is very consistent. Everybody, around 90% of this sample, was saying they're concerned about their child's motor abilities. They are far less enough to be considered a risk for DCD. And that did not change all the way to 15 years. Now, this measure went up to 15 years, so older people in this sample don't have a DCDQ, but I'm assuming it won't just go away by adulthood. It is probably a problem that continues for the person who is growing as they are trying to fit in the world. So these problems seem to persist in childhood, perhaps into adulthood, and we should consider adding motor within that ASD definition in a future revision, is what the recommendation was in the first paper. In the second paper, I looked at, okay, where would this fit? Should the motor issues be recognized as core issues? Should they be recognized as general delays? And I will tell you what I think we should do, but the data didn't suggest that they should go in one place or the other. They could go in either places because they relate to the disorder. Whatever it is that causes the social difficulties or repetitive behavior problems those are the problems that are also leading to the motor issues. And so why do I say this? I say this because in these graphs here, what I have tried to do is subgroup the population based on a particular delay. So here we have social communication delay and repetitive behavior severity. These are based on your social communication questionnaire or the repetitive behavior scale data. And what we are showing is how much of each of these subgroups has a motor difficulty as well. So does a motor problem relate to social communication problems? And so what you see is as the subgroups go from left to right, these are very low to extremely high social communication impairment subgroups. And so that also shows that the motor issues are increasing with increasing social delay. Similarly, for repetitive behaviors, as you go from left to right and the children have more and more repetitive behaviors, they're also reporting more and more motor difficulties. So the orange section are children with a motor impairment on the DCDQ. Same thing for general delays, actually. So here now we are taking the parent reported outcomes where parents say the child has no delay or some delay or significant delay, and the parents are again suggesting that they are not, the parents are not, these are percentages of data, right? So proportion of the sample that is showing a motor delay, that is increasing with increasing cognitive delay. Similar results for language delay, it is slightly, I would say slightly weaker, 85, 86, 92, but very significant for cognition as well as language. 72 to 90 to 97% of this population is reporting a motor impairment as a function of functional delay. So then the point in this paper was that, hey, you could put it anywhere, put it in core problems, you can put it as a general delay, but it needs recognizing because it is really prevalent and associated with this disorder. Because in the past, it's been described as, oh, a minimal brain dysfunction, something else, not autism, that is happening in children. And so it is not really something else, it is part of the disorder. And so should be recognized in the definition. But there are other experts who have different opinions. So there are, I can't think of her name off the top of my head, but there is an OT at the University of British Columbia who wants the motor issues to be recognized as DCD in itself. The way the DSM has set it up right now, where you need to recognize DCD if there are co-occurring motor difficulties in children with autism. The problem is nobody recognizes DCD within the US. I hardly get families or a child who's being diagnosed with DCD. That is not something that is often diagnosed in the US. It's a more common disorder for Australia or perhaps Canada, but it's not being diagnosed here. So even if that could be done better, that would be a solution. The problem is nobody recognizes that, and you don't recognize it early in life. It's recognized somewhere 6 or 7 years at school age. And so many years have passed, and services won't be provided towards motor issues in the early years. Okay, so the next half is the argument people have made on these data that, hey, these are all questionnaire data, parents are saying these things. What do you know about actual assessments, and what are these assessments telling us about whether the screening is accurate, right? So you have to validate your screening tools against true assessments. And so what is available in the Spark data is not an assessment, but it is a very popular developmental measure. It's called the Vineland Adaptive Behavioral Scales. It's used often along with the diagnostic tools of autism. So whenever you do a ADOS or your ADIR, you administer the Vineland Adaptive Behavioral Scales. And so what does that data show? So this is, here, that's this orange table here. And so this is data from two different studies. The Spark study is at the bottom, and the West Australian Register study is from Australia. It's from this paper by Melissa Lickery and colleagues. And that's in a completely different continent. And what I'm showing you is how much affected was the motor performance of children with autism across these two different studies across two different continents. And the numbers are not very different. So low scores, 17 to 35%. Moderately low scores, 43 to 60%. Total score 77 to 79%. So again, you have that 78% or so of the sample reporting motor delays. Again, these are parent questions. This is a parent questionnaire. It could be a parent interview, but parents are recognizing motor problems in a larger sample. It's in a much larger sample of children. These are all children with autism. Now, if you try to validate the DCDQ data against the VABS data in the Spark sample, because both coexist in this sample, what you find is there is around 80% accuracy, where both measures will say no delay or both measures will say yes delay. So around 80% of the time, if the DCDQ says your child has a delay, which means 4 out of 5 times, you are probably right on the mark about having your child having a delay. So it's a 15-item questionnaire. It takes 5 minutes to fill out. It's an easy addition to the VABS, which takes half hour to fill out, and to your initial screening assessment or diagnostic assessment that you do for autism. The only problem is this can only work 5 years and above. So it cannot work in that early diagnosis stage. There's another tool that could be used, and I'll talk about that in a minute. Now, there's another study that has been done in Belgium where they actually administered a motor assessment and validated that against the DCDQ in children with autism. And there too, they got 82% accuracy. So, in general, 4 out of 5 times you can feel confident about the DCDQ um, identifying motor issues accurately in children with autism. So how do you screen for motor issues? So early on in life, of course, you have many ways. You are clinicians. You know how to get information from the parents on children's motor milestone delays and look for those types of delays. There are also questionnaires like Ages and Stages questionnaire, which can be used. There are other signs. You should be looking for hypertonia and sort of that passivity in the child's affect, or perhaps opposite, irritable affect. The sensory issues really affect their state. They might have fewer postural shifts. So these are children who tend to be in that position for a long time, whichever position it is, on their belly, on their back. They don't have as much variability in their posture. And then preference for objects over people. That is another thing you see. So if you see them playing with toys and you're looking for whether they share toys with you, that is difficult for them, especially in distal communication. If you're right at their face and smiling at them, talking to them, they will smile back at you. But if they are left to their own devices, are they spontaneously sharing their play with you? That is not seen as much. And then, of course, communication delays are easier to diagnose in the second year. In the first year, it depends on the natural environment of the child. They may not be as vocal, or especially in foreign and in places that involve strangers, or that's not natural to them. They're not going to vocalize in those environments. And so you'll have to query the parent to get information on communication delays. The one tool that I did want to talk about is the little DCDQ. There's a version of the DCDQ for preschoolers, which could be considered as an addition to your tools of ADAS plus VABS. Could you add this tool so that you can be looking for motor delays and motor planning problems in preschool age? Because that is when autism is being diagnosed, and it's possible to be looking at this tool. There's another tool developed by the UBC faculty. Again, I forget her name, it's not coming to me right now, which exists and helps diagnose DCD risk early on in life, which could also be used. And in adults, in fact, this will go on because it never gets addressed. It can go on into adulthood. There is something called as the adult dyspraxia checklist, which is freely available online, which can also be looked at. And so more needs to be done. A lot of this Spark work is on DCDQ, but not a lot of work has been done in validating little DCDQ or the adult dyspraxia checklist. So clinicians should look into that, not only for autism, but for other populations as well. Okay, so why is this important? The reason why I think this is important is, many of you are physicians. You are channels or mediums through which families access services. And if you don't recognize those motor challenges, then those children are not going to receive a referral to get PT, to get recreational therapy through adapted PE. If you think, oh, they walk, they're fine, they don't need it, then they are not going to receive the therapy that addresses these problems. So this is data from the Sparks data set where I'm looking at what services the parents are reporting in their child. And the green is the percent of population that receives a particular service. And as you can see, which is not probably not surprising to us, is that a majority of the children receive speech therapy or occupational therapy around 84%, and also behavioral or ABA services around 68%. Social skills interventions are often offered to children with more understanding and language, and so that's around 47%. But PT and recreational therapies, those percentages are very low. So around 35 or 14 to 15% of children are receiving these motor therapies. And I would like to show how the motor services compare against their motor problems. So the DCDQ has many subscale, three subscales. It has the fine motor subscale, which is in blue. The gross motor subscale is called control during movement, so that's in red. And the general coordination subscale is really just how fast you are, how calm you are, how much you play, questions like that, and that's in green. And on the y-axis, you have what is called the normalized DCDQ score, which means I have taken the items, summed them for the subscale and divided them by the number of items in each subscale. So the 1 to 5 can now be interpreted just like the parent interprets it when they put their rating. So one is not at all like the skill that has been described in the item. 5 is best performance. They're doing it exactly like the way the motor skill is described. So, catching a ball or hopping, or it depends on which skill we are talking about. Because as I said, there are fine motor, gross motor, and general motor skills. And in general, we've classified the children based on their motor impairment on the x-axis. So very low motor impairment, low, high, very high, extremely high motor impairment. And what you see is, of course, the scores are going to go down, but majority of the sample lives in the high, very high, extremely high subgroup. 83% of the children live here, and most of them are 3 or below. They are not really high in their motor skills. And if you look for differences in domains, the motor domains, sure, gross motor is high, slightly higher than fine motor. General motor is even lower, even worse. So in general, these scores are pretty similar, and they are below 3. And below 3 is what would be concerning to me. You should be referring them from movement services. But if you look at the therapies they receive, there is definitely a focus on fine motor, right? A lot of them receive occupational therapy. Occupational therapy mainly addresses fine motor sensory issues, not so much gross motor issues. And these other disciplines, so this is PT, and this is perhaps adapted PE, or your other creative movement therapists. I'm not sure which all disciplines are captured under recreational therapies. Those groups are not receiving access to this population. So even though the motor services are sort of uniformly affected, the access to services is very discrepant here based on how far or how much more OT is offered compared to PT or recreational therapies. And so there's clear gaps, and that as clinicians, you need to advocate more for motor services for this population. Okay, so when I say this, the other comment I get in these papers is that, hey, that's not the only thing we need to do. Adding motor to the ASD definition, sure, you'll do that. There are so many other barriers for autistic individuals to not being able to access motor services or PA services, and those need to be addressed. So I completely agree with that, but I do think we have to start at the top. If you recognize at the top, diagnosticians will become more aware that, oh, this is a problem, okay, let's look for a screener to look at motor problems in this population, and if this child really has them, let's refer them for PT services. That can only happen if you recognize at the top. If you don't even put it anywhere in the definition, nobody's thinking about co-diagnosing as a DCD or anything like that. The other sections here are just saying that I know I have 5 minutes or 5-10 minutes, so I want to go through these sections quickly. The defined clinical pathways was to be aware of screeners. What screeners could be done at what age for an individual with autism to see if we can refer them further for motor services and assessments. Here I'm talking about, there are certain professions that don't have access to this population and have something to offer given the problems children with autism have, specifically PT, adaptive PE. And so those professions need to be able to work with this population as well. And those professions need training as well. So some counterpoints that have been made by psychologists, at meetings and talks is, I feel more confident sending this child to an OT. I'm not sure if the PT will know how to work with this child. So I agree that they should know, the PTs and the adapted PE teachers and other, exercise coaches in the community should know how to work with children with autism. So that is a barrier in general for many professions, but also because they don't necessarily get called to work with this population. So it goes both ways. And resources, there aren't proper services, so the community programs that exist don't have trained people and also don't have the built environment. Not all clinics or groups where physical activity is offered have the built environment that is appropriate for a person with autism. You can't work with that child just like any other child. So you have to know how to accommodate to the needs of the child, and that is still a barrier. And lastly, parents, are told to prioritize and themselves may prioritize speech or occupational therapy, other more sedentary therapies. ABA also tends to be quite sedentary if unless the clinician is aware. Those tend to be sedentary therapies that get prioritized over any kind of motor or physical activity. And so that's just um, something that we need to make our stakeholders, clinicians, parents aware. And there are other countries that do this differently. So, specifically, the Belgian study was done by a PT in Belgium, and she says that, hey, it's the PTs who work with this population in our country. And the same thing for Israel. This Atu paper talks about that. And so, there are other models. There's not just the model that happens in the US, where other professions have more access to this population. So, overall, I think these problems are real and that we do underdiagnose and undertreat them. And hopefully, there could be more done for specific motor experts to gain access so that they can provide services to this population. And that I agree that there are other barriers that also need addressing. And in the recent months, over the last year or so, experts have given opinions on this. Parents have actually given opinions on this. They think that they can't get insurance coverage for any kind of PT service because their child is not enough impaired, right? And so they don't get PT service access at all, even though they want their child's ball skills or whole body coordination skills to be a little better. They will never be able to justify that to the insurance claims. And lastly, there are self advocates who have described how their motor problems are and what their motor problems are. And this is a paper by Emma Gowan in UK where she's asking the adults with autism what their motor difficulties are. Okay, so the last part I'm not sure I'll be able to cover at all because I have taken a lot of time, but I can go through it really in 3 minutes if I can. So, this is the part where we've looked for evidence for motor interventions and how they can be helpful for children with autism, and why motor or especially creative movement, because that tends to be more embodied, inclusive of movement, and improvisational, not as controlled like ABA. And so we think there is a value in adopting movement interventions for children with autism. And in the recent study that we did, we looked at creative movement compared to general movement, so just exercise and games. We controlled for music and synchrony, which we think are unique aspects of creative movement. We took those out, so no music, no synchrony. You have to move in turns, so do turn taking. And then lastly, sedentary play, which is standard of care, which is usually what children receive a lot. It's modeled around OT and speech therapy. And what we find is there are more task-specific improvements. So more gross. So this is the Brunick-Sosoretsky test, which is a test of motor performance. And we find that in the movement groups, which is creative movement and general movement, there is more improvement in gross motor performance because that is what they practice. But in the sedentary play, there is more improvements in fine motor performance. And so these improvements tend to be task related. What you practice is what you improve. Then we have a task that looks at, it's called the flanker task, which is a measure of executive functioning. And there's a lot of literature on how cognitive abilities will improve as a function of physical activity. And so we see the same thing here. We've combined the movement groups because the trends were the same. And we see faster reaction time, so quicker decision making in the movement groups compared to the seated play, where we did not see as much improvement. And then we look at social skills and what is happening. Though we do see more talking in the movement groups compared to the sedentary play group, but in terms of quality, there's a lot more yellow versus green. So there's just a lot more opportunity for spontaneous communication by the child. The child gets opportunity to speak more versus in the sedentary play group, because everybody's sitting at a desk, the adults tend to ask more questions. And so that ends up becoming more of a responsive communication, which is less affected in this population. It's the spontaneous communication that is more affected. And so overall, we think that there is a lot of value for movement interventions. There are reasons for social effects, which is essentially you start tuning to people, you start moving with them, you feel connected with them. In the cognitive realm, there is a lot of evidence on how physical activity can impact blood flow and neurotransmitters, specifically in the prefrontal regions, to improve executive functioning. And in general, there are aspects of yoga and mindfulness which impact positive behaviors. And these are just fun activities that create a positive affect in the child. And there are multiple systematic reviews we've published along describing these findings. Yeah, so overall, I think this is an important problem to address in this population. Specific professions need more access to this population to address these motor issues, and that therapies should be inclusive of movement. You know, whether you're a psychologist, whether you're a physician, if you can encourage inclusion of movement and physical activity for this population, there is a lot of value, as I said, because it can impact not only motor development, but other forms of development. And I want to do one quick plug that, you know, our interventions need to be more holistic than that. So I agree that we work with children one-on-one and engage in movement with them using technologies or just people. But you could do more than that, figure out ways to educate the family in nutrition and physical activity to continue to engage in that at home. So interventions need to be more holistic, and they also need to be more community engaged and community informed, which is what Dr. Lee Pachter recommends to everyone. So making sure your research involves these community members to make that research and intervention more relevant to your population. And some beautiful work has been done by Liz Pellicano in this space in England. And so that's something to look into. All right, so at that note, I will stop. Thank you.
Thank you so much, Anjana, for this fabulous presentation. This was great. Any question?
To get out of this.
We have a few minutes. Check the chat. Oh, I have questions, but no question in the chat. All right. The interventions that you described, did you what was the age of the children, and how long how long after the intervention or during the intervention did you remeasure, the motor, the improvement as well as improvement in cognition?
Yes, yes. So these are short interventions. That's a good question. These are 8 week long, so they are only 2 months long. So because of that, yes, the amount or the magnitude of improvement would probably be much smaller. Yeah. So we always have a control group. So that's our justification for, you know, even if we have a medium-sized effect, we don't even see that level effect in the control group. Or if we have a large effect, that's not what we see in the control group.
Thank you. Johanna, did you want to, Johanna?
Yeah, yes, I actually just wanted to sort of chime in and say that this is actually very interesting. That's why I wanted to join this as well. I'm a clinical coordinator at Easter Seals on the Eastern Shore of Delaware. I'm also a play project consultant, supervisor, and master trainer. Play stands for Play and Language for Autistic Youngsters. It's an evidence-based autism intervention. And what we do as part of that is we do a sensory motor profile of the child, whereas we're not necessarily occupational therapists, but we're all trained to be able to do that and to accurately profile the child from a sensory motor standpoint. And we use sensory motor play within, the interventions. And there is a huge correlation between giving the children with ASD the sensory motor input, the sensory motor play, and interacting with them from a sensory motor standpoint. And it's really vital to what we do, and it is extremely effective. So this is really interesting to me to see, that there are actually motor differences, motor difficulties in these kids, which makes sense, especially when we're talking about, multi-step movements, because we all know, when you're that's challenging for them and making all those connections. And what we see very often is when you accurately profile a child from a sensory standpoint, whether they're a seeker, whether they're over responsive, under responsive, and you meet them and you get them in that good sensory spot and you give them that input, movement, we get more language, we get more joint attention, we get more engagement because the children are regulated. So it's very closely correlated. So this is very, very interesting. And I just wanted to kind of chime in and say it's all very related, and I'm really glad that you're exploring this piece of the ASD diagnoses, because I do think that it's an entire body system, and you have to have that holistic intervention in order to be able to help these children sort of get better and move along. And so this is very interesting. Thank you very much.
Yeah, thank you so much. It's always good to hear a clinician, validating that, hey, your data are not just data. We are actually trying to implement that in the real world, and that looks like that's what you're doing exactly. So thank you for that. And
Absolutely.
I, being a PT, I'm not like an expert in sensory processing issues in autism, so I don't talk about it. But I completely agree that there are significant sensory processing issues which interact with motor performance. And so, to think of it as one sensory motor issues is completely appropriate. And I'm glad you're doing that.
Absolutely. And you'll notice that a lot of some of the perseverative behaviors that we have in our kids are motor related, right? Flapping, spinning, jumping, wandering. And so it would also make sense, right, is to use that as an intervention, and that those systems are very connected. So this has been very informative. So thank you.
Yeah, thank you.
Any other question for Dr. Bhat? Well, I have another question. So do you think that, I guess, the younger the child, the younger the child, the younger the child, the better it is to start this type of intervention, right?
Yes. But if it's possible to diagnose, yes, to start earlier is better. Yeah.
So do you still see progress if you start with older child? I mean, are they still, can you see progress or improvement in their motor skills as well as in behavioral skills and cognition?
Yes.
In older child?
In the children in fact, I took some data out because I didn't want to overwhelm people, which I probably did anyways. One set of data that we've done multiple RCTs of the intervention. The first RCT actually showed smaller improvements in movement skills and more improvements in the social communication domain. So in fact, there can be quick, because ours is just a 2-month intervention, we see more improvement in social communication than movement. So we do change them, but to change motor skills is hard because we are looking at whole body coordination, complex skills. So in fact, I think the benefits of movement interventions are in the other domains more than the motor domain. But it is possible to change. The changes are smaller in the movement domain.
That's fascinating.
Yeah.
All right. So I think that's already one. Time flies.
Yeah.
Well, thank you so much. And if there is no other question, I think we'll adjourn. And this was really fascinating presentation. Very, very